Okay, so my name is Summer. I am a RBT in South Florida. I've been an RBT for about 5 years now, and I predominantly work with kids under the age of 10, 10 and under.
My name is Emma Jones. I am an RBT in New Jersey. I currently work in a private school for autism. We do ages 3 all the way up until 21, and I have been in the field now for 4 years.
My name is Emily Schulte, and I have been an RBT for about a year and a half, and I mainly work with kids 3 to 15 in a clinic.
So today we are going to be discussing collaborating with colleagues within ABA. Other colleagues can include SLPs, speech therapists, occupational therapists, physical therapists. Today, we're going to cover the importance of collaborating with healthcare professionals. We're also going to discuss a broadhead flow chart, which kind of discuss how can we collaborate within clinics and settings in between non-behavior and behavioral analytic treatments. And then we're also going to discuss why ABA should be implemented more often and often in public schools through behavioral clinicians.
So we went over all this. We're going to talk about each topic, and then at the end, we're going to have a little Q&A.
Great. So we're going to start with collaborating with other healthcare professionals and why it's beneficial to the clients.
So, BCBA's collaborating with other healthcare professionals is very important to maximize client benefits and outcomes. Effective collaboration results in better generalization of skills learned and maintenance of acquired skills, as well as better problem solving, and also provides a wide range of additional resources that are outside of that practitioner's field. There are many types of collaboration approaches, but the best one is interdisciplinary approach because it allows BCBAs to promote ABA to other related healthcare providers, which can build trust and create partnerships with other providers to benefit the client. OT, occupational therapy, involves the use of sensory integration therapy, which is an evidence-based practice, but there's not much evidence on whether sensory integration is less reliable than interventions in ABA. Another counterpoint to that is that clients who receive ABA receive services from 10 to 40 hours per week, whereas clients who receive occupational therapy services receive them 2 to 3 times per week for 30 to 60-minute sessions, which, in my opinion, is not long enough to create any meaningful change.
I would definitely agree that collaborating with other professionals is super important for client outcomes. I think a lot of times in the field, people think that ABA is the end all be all and it's superior to other treatments, when in reality, you need an integrative approach to treating individuals. And I've seen a lot of clients who have had really great outcomes from doing OT combined with ABA along with speech to work on those communication skills. You really can't, in my opinion, have one without the others.
I totally agree with the both of you. Me specifically, I had a client who didn't have many behaviors, however, really benefited from occupational therapy. So fine motor wasn't amazing, and us being an ABA, as we know, we only do so much as far as those specific fine motor and gross motor skills. So working with the occupational therapist, we were teaching like functional play, just inputting a puzzle into its piece. However, being able to collaborate with the occupational therapist, really focused on like the gripping of the piece and the motor movement and transitioning through. And like Emily said, sometimes those 30-minute sessions aren't enough. Like, we see our kids for hours at a time, for hours a day, and those specialties like 30 minutes. Sometimes you do get an hour, also depends on the insurance cost, which is also a thing that we suffer from. But even with that collaboration aspect of seeing us for hours a day, and then that 30-minute being able to collaborate, we can carry that over, especially if the BCBA is, aware of what's happening in the OT sessions, that we can implement some of that, respectfully through ABA at the table when we collaborate within each other. So I 100% agree. One thing I also noticed, just to touch base real quick, in schools, OT isn't that effective, especially if you have a behavioral client that can't seem to, sit for a long period of time or even work with someone. That's when a good time for ABA to kind of, get the ball rolling, because we can build on that toleration skills, and we can build on, taking direction from other people, which also comes in handy when we collaborate with the OTs and the SLPs.
Mm-hmm. One other thing about collaborating is I work with a lot of speech therapists in the schools, and they are really great to work with when it comes to communication devices and putting things on the communication device that help with our ABA work. So I think it's great.
Yeah, that's a really good point, because there's a lot of like programs. So you have like your Protocol and you have your Touch Chat, but now it's expanding, and I am not always tech savvy. So recently I noticed that Android has their own like devices. We get conditioned to like the iPads and Apple, and I have not crossed over into understanding like how to do it on a regular Android tablet versus an iPad. So that was a good point.
All right. So
This is the visual for the previous topic. The first approach is multidisciplinary, which is, from my understanding, just professionals working in parallel, so just next to each other, not really providing ideas to each other, just kind of there. Interdisciplinary is a better approach because you are communicating about goals, you have shared goals and responsibilities, and you're maintaining those roles while also collaborating with the other professional. Transdisciplinary is the next approach, and it is more, I don't really know how to say that. The treatment plans are unified and it's problem solving, but interdisciplinary is better because it's basically half and half, and both providers are giving their 2 cents into the treatment plan.
definitely, I would agree with that. And especially the part that says frequent communication. I think when you're collaborating, really touching base and speaking on the phone or face to face to really get on board with each other with the goals for the client that you're trying to reach together.
Yes. Even also with the frequent communication, I know RBTs and sometimes BCBAs don't always like see eye to eye, but that frequent communication, letting the BCBA know like, hey, I've been trying what you showed me, but it's not really working. Being able to have that open conversation and that open dialogue, that way, the client does get the best treatment, and it's not like, oh, I kind of just skipped over it, or I didn't feel comfortable saying anything. It's that interdisciplinary is like important, and also like share the goals and responsibilities. Yes, we implement the treatment, but we still need to collaborate with the BCBAs, and the BCBAs have to collaborate with the parents to make sure that, like everyone's on board. It's being generalized, it's being carried over, and it's also maintained. Like, I don't know about you guys, I come from a center that we always did maintenance Mondays. So no matter, yes, you have new goals, but make sure at some point in time in the day you worked on the goals that the client has already mastered to make sure that everyone's still on the same page. The SD is still, effective, and the treatment is still where we left it off.
Yep, definitely. All right. So next, we're going to talk about the broadhead flowchart for analyzing non-behavior analytic treatments. So caregivers or other providers may suggest treatments that are not behavior analytic in nature. So an example of that could be a parent wanting to try a gluten-free diet, an OT suggesting more sensory input, or anything along those lines. So this flowchart is really helpful to determine if the treatment is worth addressing. So this is a great way for BCBAs to engage safely and collaboratively with other professionals with the end goal of doing what's best for the client. So a counterpoint to that is that the flowchart does offer good bones, but it might not necessarily be practical for every situation. So if you're a BCBA in a meeting with a speech therapist and an OT, maybe a social worker, you might not want to whip out this piece of paper and kind of like start going through it one by one. You might look a little bit rigid or, not willing to hear opposing opinions, which I definitely understand. So this is relevant to the ethics code of practicing within scope of competence and also providing effective treatment, because at the end of the day, we do need to stay within our scope and do what's best for the client.
Agreed. One thing that I do like about the flowchart is we often kind of feel uncomfortable with, disagreeing with someone, or let's say you happen to share like a therapy space with someone else and that client is more, rowdy than the next, but you don't want to come off as like being a brat and saying, oh, okay, you quiet your client down. So I feel like even if they implement it, not necessarily for like a scenario shouldn't have to arise. Like it could be optional based, like, hey, like just so here's an option that if you ever feel, here are some steps you can take to like preventative measures. Like we always talk about antecedent interventions. I feel like this could also be a good antecedent intervention for us adults, especially in clinics, and being able to work through problems without it actually arising to a point where you need the flow chart and the flow chart is not an option.
And it's also really great if you're in a situation where you're having conflict in the workplace about a treatment. You could also just look this over in your free time and kind of organize your own thoughts without doing it in a meeting or something like that.
Definitely. Especially like when I looked at the flow chart, one of the biggest questions that stuck out to me is the safety at risk.
Mm-hmm.
I feel like we go through so many behaviors, like, SIB, for example. We always like, do we block that? Do we leave it? Because in that moment, you have to decide, like, is it at risk or is it attention based? And I feel like that flow chart, especially someone that's new to ABA and new to like those high risk behaviors, this is something that can ease your mind. You can go through the questions in your head. You can even, ask your BCBA for 5 minutes beforehand, 5 minutes afterhand to see like, this didn't fit me necessarily. However, I noticed for when he was SIBing, it interfered with that goal.
Right.
So
exactly.
This can definitely carry over into like behavior and non-behavior.
Mm-hmm. So we'll go ahead and take a look at the flow chart here. Okay, so as you can see, it's pretty straightforward. First, you're going to identify the treatment that's up for discussion. And of course, like Summer said, client safety is always the number one thing that we want to look at. One thing that really sticks out to me that I like about this chart is, are you familiar with the treatment? Because a lot of times we might not be familiar with it, and you don't want to be too quick to write it off, because at the end of the day, it might be beneficial to the client, especially when it comes to things having to do with OT and speech. a lot of those things, obviously, we don't learn about that in our ABA program, but clients do have really good outcomes from that. So this is a great way to just keep an open mind, do some research, and learn more about it before you just immediately write it off.
This is also to touch base on the being familiar with the treatment. Another way to collaborate, like with your colleagues, ask another RBT in the room or another BT, like, hey, like, have you ever seen someone implement this? Because as we know, the BCBAs aren't always available, like support isn't available immediately, but being able to collaborate with another RBT that's either in the room or has ever worked with that kid before, you can say, do you mind showing me? Because even then you can either learn about something you didn't know, the client, you might have been presenting it the wrong way, and you can learn using the questions to ask, collaborate with somebody else, instead of always relying on the the BCBA, because we often forget that we have each other to lean on. Right. And we can always like, hey, can you show me this goal? Like, if you're not busy, if you're not in doing DTT, I like this chart a lot.
Yeah. And the fields of ABA, there's just so much to know, and clients are all so different. So really just taking your time to talk to other people, get ideas, learn from them, teach people things that they might not know, and vice versa can be really helpful.
I definitely agree. Also, sorry, but another thing I like was does it negatively interfere with the goals of the client? I noticed that the word negative kind of gets a bad rap in ABA. Mm-hmm. So let's say you're hypothetically training someone, he's like, oh, did it have like a negative effect? And they're thinking like, oh, yeah, it had a negative effect. The client had a behavior. He was like, well, no, not in that sense. Like, did it promote, like, hypothetically, the client to not do any of his work? In situations like that, I feel like people get stuck on like the term negative and not necessarily understanding that it may have a good impact. The client just didn't like it, which would serve a completely different purpose than it having a negative impact on the goal.
Right. All right. So next up, we have why ABA should be provided in public school classrooms.
So, just a backstory. I've shadowed kids in public schools for the last couple of years, and ABA doesn't have the best rep in public schools. And I do feel like a lot of it comes from just lack of knowledge. But when it comes to ABA and clinicians, we are there to support the kid. We are there to push the kid to their maximum potential. We are there to support the parents and the teachers, while also like providing, communication skills and decreasing those behaviors. Personally, right now, I'm working with a kiddo who likes to scream in the middle of class. And the teacher basically asks, like, what was the purpose of me if he still screams? And we know that it's attention-based, so we don't give that attention. But on the outside looking in, someone who does not come from an ABA background, it just seems like I'm allowing the kid to scream. So the counterpoint of that would be a lot of teachers are self-taught when it comes to dealing with behaviors, and which kind of determines that negative aspect of us. There's actually been studies who have interviewed teachers who determine that they don't have many resources as far as like behavioral tools. They don't have many, they don't have time to implement all the skills we implement. Like a math problem to a teacher is like 3 + 3. Mm-hmm. Us, we kind of break it down. Like we have 3 here, and we implement visuals, we implement hand over hand. And ABA has to understand that the teachers don't have time for that, but the teachers have to understand that ABA has all the time for that, and that's our main goal. Also, we understand that, what we do can be a little time consuming, and it may cause some interruptions in class. For example, we often provide non-contingent reinforcement. So if a kid is sitting nicely, we're going to say, thank you for sitting nicely. We're going to implement all of those little moments where a teacher is like, he's in my classroom. We shouldn't have to like thank him for sitting. And we understand that, but also our kids require more than a neurotypical kid. And we have to be mindful of, when we're in this environment, we have to teach them to adapt. And I'm noticing in public schools, that gray area where ABA kind of lies, a school is more black and white. Either you can do it or you can't. Either you can participate or you can't. Where we look for reasons and ways to promote that, interacting with peers, or, we often sometimes neurotypical kids will ask us, why doesn't he talk, or why won't he play with me? And with the teachers not having the skills and the knowledge to implement more inclusion, it kind of also runs the risk of ABA not being wanted in public schools, because it's like they always have to justify why our kid is doing what they're doing when it's not necessarily the case. And for me, the code of ethics of that is like, our responsibility to the client is to make sure they are getting everything they need across the board. They're getting the same opportunities that we give a regular neurotypical kid in school. But I'm also noticing that it is a little time consuming, but it's not incapable. Like, our kids can do it. It just takes a little bit more steps.
Definitely. One thing that I think about a lot is special education teachers. They might have their teaching certificate, all that, and then they go and they work in a self-contained classroom with all autistic students, and they have no background in ABA. So
Correct.
I think is an issue. So I think the schools need to do a better job at giving teachers at least a baseline knowledge in ABA when you're going into these classrooms.
Agreed. Because even if we have Autism Awareness Month, I don't know about you guys, but that's the only time I'll hear a teacher mention the word autism or inclusion, is when, they have to do that one little project for the school. However, even in those moments, it's just a day, or it's just like an extra lesson the teacher has to do. There is no actual training on it. The teachers aren't getting necessarily the actual skills to teach what it means to have autism, or to teach what it means to be inclusive, or a child is different. That was actually one of the articles that discussed that some teachers have become inclusive teachers without knowing what inclusive means.
Yeah.
Like, the principal just like, oh yeah, you're an inclusion class, and it's like, okay, but now you have a kid that may have ASD, or you may have Down syndrome, and now they don't understand what they signed up for, and they don't have the proper skills to attend or to teach that one kid.
Yep, exactly. And
One thing that I have, oh, sorry, Emma.
Go ahead.
One thing that I have about this point is that I've seen it before. School administrators, even when a child acts up, especially in a special education classroom, their first thought is, oh, we're going to call the parent and send this child home. When in retrospect, that child is probably engaging in that behavior because they want to go home. So then we're therefore reinforcing that, and the behavior is just going to get worse. And so I feel like ABA should be provided to public schools and trainings on how they can handle that differently.
Definitely. And another thing too is I also think that it should be included in public schools, is a lot of kids and families don't have the means to receive services outside of the public school system. So in school is the only place that they might be getting any of that therapy.
I agree. And also with that, even like you said, that short amount of time, especially with the OTs and the SLPs. Like I've had clients who I shadowed in school, and you say like, oh, your client gets 30 minutes of OT, and in reality, it's not 30 minutes, because by the time you transition a kid to the room and actually start the activity, you've lost about 5 to 10 minutes. And now a 30-minute session has really become a 15-20 minute session. You didn't get to really implement what you wanted to implement. And now it leaves the RBT to retransition the child back to school. And then you got to reacclimate to the environment, because our kids aren't always able to walk back in and start doing, whatever the class is doing. We have to kind of recalibrate what's going on. So I know that a lot of schools, they do have autism coaches.
Mm-hmm.
I have not necessarily seen their strengths in supporting us, especially the RBTs that come in. And also, they don't always have like the visual schedules. And, a lot of teachers say that's tedious, or they don't have that enough time in their teacher planning time to specialize a individual schedule for a child, which again, we completely understand that, resources financially and people, there might not be enough bodies either.
Right.
But I'm also noticing that even in, like Emma mentioned, the classrooms with all ASD kids, not even the aides or the paraprofessionals are equipped. So they're placed in a cluster room or an ASD room, but they don't know what they're necessarily working with.
Right.
They don't understand what it means to be on the spectrum, and like the spectrum requires different needs. Not every kid is going to be verbal, and some kids might be overly verbal and they don't have that balance.
Right.
To move on, one thing that stuck out to me was the amount of strategies that diminish over the years. So in preschool, there's a lot of, colors and visuals, and the teachers sing, and same thing with elementary school, like it's more, hands-on. But as our clients get older, they lose out on those visual schedules. They lose out on those reminders, because our teachers aren't taught that those things have to be carried over throughout their years. Like, just because they're in high school doesn't mean they're mentally high school. They still might need that visual schedule. They still might need a sensory break. They still might need a, more functional communication training. Like, as we get older, we experience different things. We don't know everything in that moment, and we can't teach a 5-year-old, how to cross the street immediately. Like, it's different levels, and over time, it kind of fades out in public schools of what our clients need.
Definitely. And it also emphasizes the importance of continuing education for teachers who are in those classrooms.
100%. 100%.
All right, so now we have our Q&A section here. So we have a couple of questions. First, what is an example of a situation where the broadhead flowchart might be used in a clinical setting?
I would say RBTs, I feel like for me personally, I think it would be best between an RBT and a BCBA, for the simple fact that, we don't always have the same BCBA. Like, I've known people that's had the same BCBA for the same client for a long time, but you could be a language barrier. It can be a culture barrier that might determine, oh, I don't want to work with this person because they don't have to, necessarily have the skills to work with that specific client. So I think when it comes to RBTs and BCBAs having a decent bond, I think the flow chart would be a good option.
Definitely. So are there other ways to resolve conflict in the workplace without the broadhead flowchart? Of course, you can, have a conversation, but if something is really complex, I would say that the flowchart is the best way to really get your thoughts together and determine appropriate treatment.
Agree. Like Emma said recently, should school have ABA training courses? Yes, we definitely should. Even if it's, paired with a clinician, a BCBA or some sort, school should definitely be more willing to open the doors and collaborate. And it's simply to benefit the client and the kid and those on the spectrum who don't necessarily have a voice to advocate for themselves.
Mhm.
I agree.
And
And
lastly, what collaboration approach is best to maximize client outcomes?
I think the best collaboration approach is the interdisciplinary approach, just because it seems like the easiest way for both providers to, like I said before, put their 2 cents in. So we're maximizing the client outcomes to the best of their ability and benefiting the client as best we can.
I agree. And like we all said, open communication, like having that, the parent, the physician, everyone involved should, be able to respectfully say, I don't think this works or I think this works, and be able to collaborate with one another. That way, the client, we do have their best interest at heart.
Right.
Definitely.
So, sorry.
So, based on our research, the three of us, we have concluded that collaborating with other professionals in ABA settings, including public schools, is beneficial in long-term outcomes for clients as well as their families. While conflict is inevitable in the workplace, we also concluded that the broadhead flowchart is a reliable way for behavior analysts to work through the challenges and maintain collaboration within the workplace. Obviously, conflict can arise when being presented with non-behavior analytic treatments from other professionals as well as families. But like we said, that's a great way to work through it as well as keeping an open mind.
100%. 100%.
All right. Well, that concludes our informal debate. We hope you guys enjoyed, and we can't wait to watch yours as well.
Thank you.
Thank you.